Hello, I'm Sarina Schrager. I'm a professor of family medicine at the University of Wisconsin Department of Family Medicine and Community Health. Today I'm going to talk about treatment of vasomotor symptoms. We're going to describe the epidemiology of vasomotor symptoms in both perimenopausal and postmenopausal women, review the pathophysiology of vasomotor symptoms, and explore some treatment options for vasomotor symptoms. Okay, so vasomotor symptoms or VMS are defined as hot flashes or night sweats. Really like a sensation of increased heat, flushing. It happens in the upper body, often can be associated by a rapid heart rate and anxiety. Um, this is a really common symptom of menopause. Up to 80% of women will describe some vasomotor symptoms during the menopausal transition. The median duration of some vasomotor symptoms is over 7 years, which is depressing for midlife women, actually. There is some racial disparities as well, in that African American women tend to have more severe vasomotor symptoms that tend to last longer, a mean of 10 years as compared to white women, which have vasomotor symptoms for a mean of 6.5 years. So implications, besides being uncomfortable and challenging, vasomotor symptoms are associated with sleep and mood disturbance, loss of work productivity, increased healthcare utilization and cost, but also can have recently been found to be associated with a future risk of metabolic syndrome and cardiovascular disease. We don't know anything about causation, so this is just an association, but something to think about for your patients who have severe vasomotor symptoms. They may be people at higher risk of metabolic syndrome and cardiovascular disease. So the pathophysiology of vasomotor symptoms is exceedingly complex, and that's why I put this slide in. Not to talk about the specifics, but just to give a visual expression of that complexity. One thing that I do like to use thinking about this slide. So on the left, we're talking about the decreasing estrogen. One of the ways we treat vasomotor symptoms is just to give estrogen back. The middle part, all the different things happening in the hypothalamus. This is where some of the new neurokinin receptor antagonists and agonists are actually working. So in this complex interplay of the thermoregulatory pathway in the hypothalamus. And then on the right, looking at the actual changes, in my mind, I think about these are lifestyle changes that we can make to decrease the impact and effect of the vasomotor symptoms. Okay, so treatment options. So we think about a lot of people want to try behavioral or lifestyle modifications first, meaning wear layers, avoid spicy foods, don't go in saunas, limit your alcohol, avoid hot tubs, all those kind of things. Some people I even see bringing a little fan with them. There are some also complementary therapies, so herbs and teas, and those have shown mild benefit and certainly most of the time don't cause harm. And so we encourage people to use those. We have now a growing list of non-hormonal treatments that are showing promise in reducing menopausal symptoms, and then ultimately hormone therapy. Like I said, if you're losing estrogen, just giving estrogen back, but confers some excess risk, and some people are hesitant to try hormonal therapy. So the lifestyle modifications really work mostly for people who have mild vasomotor symptoms. So again, wearing layered clothing, avoiding spicy food. There's really not enough evidence to recommend exercise, although we always recommend exercise for everything else. So certainly we don't want to discourage people who are using exercise. And hot yoga is a big thing that might actually make your hot flashes worse. Non-hormonal treatments, there are growing bodies of literature showing that both SSRIs and some SNRIs are really useful and helpful for vasomotor symptoms. Gabapentin is another often used medication, usually at night, for people who have night sweats and hot flashes that are waking them up multiple times at night. Clonidine is not used as much just because of its side effect profile, but can work well. And then the new kids on the block, the neurokinin inhibitors, fezolinetant and elinzanetant, have both shown promise in directly improving vasomotor symptoms. Okay, so SSRIs, at this point, paroxetine is the only FDA-approved SSRIs for vasomotor symptoms. And paroxetine shouldn't be used for people taking tamoxifen. But escitalopram, paroxetine, and fluoxetine have been shown to work very well and may work better than the other SSRIs. Obviously, some people have side effects with SSRIs, and that may limit the utility of their treatment for vasomotor symptoms. SNRIs, there's good evidence for the benefit of venlafaxine and desvenlafaxine, but there's really not enough data to evaluate the benefit of duloxetine. So these are great options for people who are having vasomotor symptoms and want to try something besides hormonal therapy to start out with. These neurokinin receptor agonists are newly approved. They're really effective versus placebo. I haven't seen any comparison trials between them and either SSRIs or them and estrogen, but certainly promising. Elinzanetant has dual effects. It works on both neurokinin 1 and neurokinin 3, and has been shown to probably be better than fezolinetant. Fezolinetant can cause elevated LFTs, and elinzanetant can cause headache and fatigue. Both are expensive and at this point not approved by a lot of insurance companies, but would maybe need prior authorization and a person would have to fail other treatments before they would be approved. So menopausal hormone therapy. So up till now, I've talked about the non-hormonal treatments for menopause. Honestly, menopausal hormone therapy is the most effective treatment for menopausal symptoms, including vasomotor symptoms. People with a uterus need to have estrogen plus progestin because estrogen alone can cause proliferation of the endometrium and increase risk of endometrial cancer. If somebody doesn't have a uterus, estrogen alone works very well. The estrogen patch confers less risk of thromboembolism, which is one of the big risks in estrogen therapy. I like this slide because it gives you sort of a green, yellow, red looking at thinking about risk profiles for using menopausal hormone therapy. So if you're low risk, your menopause is recent. The Women's Health Initiative was looking at hormone therapy after menopause, and a lot of the people in that study had been through menopause for at least 5 to 10 years, and that conferred increased risk of heart disease. So if you have, you're within 5 years of menopause, normal weight, normal blood pressure, you have a 10-year risk of cardiovascular disease, less than 5%, have an average risk for breast cancer, you have a green light for menopausal hormone therapy. The yellow light are people who maybe have some some risk factors for cardiovascular disease. Maybe they have diabetes or smoking or high blood pressure. Maybe they have metabolic syndrome. Maybe they're at intermediate risk of breast cancer. Those are people that, you have a yellow light. So you're really thinking, it's not that I would never prescribe hormone therapy for these people, but I would try some of the other things first. And then a red light, really people who are not great candidates for menopausal hormone therapy, they've had a stroke, they have breast cancer or at high risk of breast cancer, they have a history of some kind of cardiovascular disease, they've had a venous thromboembolism. So these are the people that really are not eligible for hormone therapy. But if we think about our practice, the majority of people are in that green and yellow light. So there is, since the Women's Health Initiative, I feel like the field of menopausal medicine has had whiplash because before the Women's Health Initiative, lots of people were on hormone therapy. Then after, nobody was on it, and now we're sort of easing back to a reasonable way of prescribing menopausal hormone therapy. And that is all. Thank you very much.